Well, I'm so really honored to be speaking to you here today, the leaders and practitioners and supporters of family medicine. I am leaving for Haiti in the morning, and I'm going to be filling myself up with all of your energy and love and bringing it with me on that mission trip. So this is a special night. I want to make sure my technology is working here. Yes? Good? Okay. This is a picture of my home. It's a painting of my home in Santa Barbara, California. This is one of my homes. As many family doctors do, I work at a distance from my home. So Santa Barbara is 300 miles away from where I'm now practicing medicine in Eisenhower Medical Center in Rancho Mirage. And we're starting a new residency program in July. And my colleague Tate De Leon is somewhere out in the audience here, and we have a table in the residency fair, so I hope you'll learn about our new program. But we are going to be having 8 positions opening up, and we have a beautiful, which is the hospital, Eisenhower Medical Center. This is our clinic building. Our medical program director is Dr. Strom. Here are some of our core faculty. So this is why I left my private practice. I really wanted to be part of creating a new family medicine residency program. I believe so passionately in family medicine, and as all of you do as well. So family medicine is absolutely the bridge to care for all. There's no question about it. And I'm going to be talking in a moment about how important it is to realize this on a global scale with PEPFAR 2. If any of you are connected in with global health movements, there's some really exciting things happening worldwide with family medicine, but also if we look at the most vulnerable people in our own communities, there's no better bridge to getting care to the $1 million Murrays and the hot spotters than family medicine leading the way. So truly, we are the bridge. And as I enter into this talk, I want to lay out the ground rules, which I know we all agree on, because we're all in the family medicine world. But to talk about Dr. Starfield, one of the great leaders of our profession, and her 4 cardinal C's of primary care: contact, accessibility, coordination, comprehensiveness, and continuity. And I just had the privilege of hearing Dr. Rich Roberts speak at the Global Health Conference that was just in Minneapolis, and he gave a 5th of courage. So as I give my talk, this is woven, these principles are woven throughout everything I'm going to say, that these principles of primary care are absolutely essential to have any effect whatsoever that's positive. And also this principle of Dr. Starfield that as we get more primary care presence in a community, costs go down and outcomes go up. So we get improved care when we have primary care. And when we look at the extremes that I'm going to be talking about, both street medicine and VIPs, for example, what you'll find that is common is that these things are missing. There's no coordination of care. Family medicine is not present. You know, there is not the continuity. And so focusing on this truly brings, these principles truly brings the best care to all people. And some other principles I want to focus on are the principles of my mentor and who I'm so privileged to work with at Eisenhower, Dr. Joe Scherger. And he talks with us as he's creating this new primary care system, which includes family medicine at Eisenhower Medical Center, about principles of the patient-centered medical home and practice transformation. So he says if there's 2 words you want to remember about the patient-centered medical home, it's care coordination, and that we need to be strategically proactive, continuous with our care, and patient self-management. These are absolutely essential principles, again, that will be woven throughout my talk. But he recently gave me a pep talk, and as I go through my presentation, I'm going to be sharing with you some of the pearls of wisdom that have really helped me over the years. Since this is an education symposium, I think pearls of wisdom, they take us so far. We can hear something 20 years ago, and that pearl of wisdom will keep working through our minds and our hearts as we practice. And one of the things he said to me just recently is what I call the 80-20 rule. Is he said, Mimi, 80% of your patients are going to be easy. You know, they're going to come to appointments on time, they're going to do what you say to do, and you're going to feel like a great doctor taking care of those patients because you're so good, because they do everything you say. And the other 20% are going to be challenging. They're not going to necessarily follow the recommendations, they're not going to come to the appointments. They are going to be doing things you don't even know about until you find out, 3 appointments later. And he said, that's the beauty of the practice. And really, this helped me a lot because I've been frustrated with that 20%, And I've just really let that go and realized that 20% is what makes us better doctors. We learn from them, and they lift up our practice. And so it's very important to embrace the 20% and not see them as the overutilizers or superutilizers, but really the ones who are going to teach us to be better. And if there's one message of this entire talk, it's how the challenges in our practices are where we learn throughout our careers to be better. Another pearl of wisdom was given to me by one of my attendings at Contra Costa Regional Medical Center where I trained, Dr. Sonia Sutherland. And she said, you need to know where someone is coming from to know where they're going. It's so true. So I'm going to share some things about where I'm coming from so you can know where I'm going. When I was a Stanford medical student, went and heard Dr. Jim Withers speak. Do any of you know the work of Jim Withers in street medicine? He's one of my dear friends and one of the most important teachers I've had. So I was at an AMSA convention. I went and heard Jim Withers speak, and he talked about his program in Pittsburgh, Pennsylvania called Operation Safety Net, where they take multidisciplinary teams out to take care of the unsheltered homeless. And that talk, when you go to a talk and all of a sudden time stops and your whole view of the world changes, that was it for me. I knew that one day I was going to have to start a street medicine program. It just absolutely transformed my vision of what it meant to be a doctor. And I'm so pleased that I'm still friends with Jim, and right now Street Medicine Institute is having their annual conference in Salt Lake City. So if any of you are interested in street medicine, they have an annual conference too. Eleanor Roosevelt has this great quote that you gain strength, courage, and confidence by each experience in which you really stop to look fear in the face. You're able to say to yourself, I have lived through this horror. I can take the next thing that comes along. You must do the thing you think you cannot do. People say to me, aren't you afraid, to practice street medicine, to go to Haiti? Yes, I'm afraid. Do I let my fear stop me? No. I've become comfortable being uncomfortable. And I am afraid to go to Haiti. It's violent. We're locked into the hospital. We can't leave. We're working in the only trauma hospital in the country in Port-au-Prince, but it's not going to stop me. I'm still going tomorrow. And I really appreciate this quote of Eleanor Roosevelt. Now, when I heard Jim Withers speak, it terrified me to think about street medicine. And I promised Jim I would share this with you, Jim Withers, that when I was a child, I was homeless. And I've not ever talked about this before in a public environment. But he challenged me, and he said, you need to talk about it because you need to know where someone's coming from to know where they're going. I experienced homelessness as a child, and that child still lives inside of me. And what that child thought was, when I get to be a grown-up, I'm going to change the world. I'm going to make it a better place because this is painful, and I don't like it. So, those children live inside of us, and they drive us to make the world a better place. So another friend of mine challenged me. She said, give a 6-word memoir. So I said, giving myself to the doctor's calling. We need to stop thinking about reimbursement and money, and we need to just do our calling. We are family doctors. We're put on this earth to do this work. It's what we're meant to do, and we just need to do it the best that we can while we have this precious gift of life and air in our lungs to breathe. So that's what I do, and I know that's what all of you do because I've been listening to you all day with your beautiful comments and talks and presentations. So we're very privileged, aren't we, to be in this profession. Okay, another one of my teachers, Mark Stinson. When I was at Contra Costa Medical Center, he's a family doctor, an ER physician, and every major disaster in the 10 years before he died, he was there. He worked every holiday, everybody's birthday, so he would get time off so he could deploy. He died in his sleep. We believe it was from complications of 9/11 because his DMAT FEMA team was the first team to go into the pit of the World Trade Center on September 12th, and they didn't wear respirators. He was a very healthy man, and he died in his sleep several years later, excuse me. But when Mark and I he was my attending, we'd sit in the ER at 2 in the morning, and he'd say, I want you to come on my next deployment. And I would say, Mark, I can't. I have kids. It's hard enough that I'm a doctor, and I'm a resident. I can't go overseas with you. Let's do something at home. Let's do this work together here at home. So we So I was able to bring together Jim Withers and Mark Stinson and get them to meet in 2005. And at the time, this was a really radical idea that street medicine and disaster medicine are the same. Unsheltered homelessness is a chronic disaster. And the principles of disaster medicine, when used, can be applied to street medicine. So this is what we did. We got together and we came up with this idea of creating a nonprofit that would bring together the principles of disaster and street medicine. We called it Doctors Without Walls. Created this nonprofit in 2005. It's still going strong in Santa Barbara, which is where I'm from. So we decided to do it there to make it easy on me. So what is street medicine? Street medicine is medical care for extremely vulnerable people where they live. That's how we define it. And the mission of Doctors Without Walls is to provide free volunteer medical care for the most vulnerable when and where they are in need, including in times of disaster, and to educate those volunteers in the excellent practice of humanitarian medicine. So this is how we started out. Here was our first team, modeled after what Jim Withers was doing in Pittsburgh. Some very important things about this team. In the front, this is John Baker. He's a two-time Army Ranger combat veteran just back from Iraq. And he'd come back with absolutely extreme PTSD, and he found peace and place and meaning in being our security. He never touched anybody. He just stood and watched over us while we were doing our work and kept us safe. And it was just absolutely so uplifting for us to have John Baker with us. This is our first team. Here we have two social workers who are mental health social workers who, in their day jobs, work with the unsheltered homeless, and at night they volunteered with us. This is actually night. Bobby Gaines is the head of the VA. He's an internist. So this was our very first team. We're carrying medicine in our backpack. And now in 2009 it expanded and expanded even more, and this is all volunteers, very, very little administrative cost. But the principle is modeled after Operation Safety Net in Pittsburgh. Multidisciplinary teams. The teams can have 7 members. A doctor, a nurse, a PAC pharmacist. We don't write prescriptions, we dispense medicine, a scribe, a student who does hospitality, handing out sandwiches, who else? And a social worker, always a social worker. So multidisciplinary teams, critical to any good primary care. We have clinics we set up in parks where there are free clinics served by churches, and then we're still using the PAC team model, but instead of walk rounds, we'll actually be in a fixed spot, always the same place, every week, same team members. So why Santa Barbara street medicine? I mean, Oprah lives in Santa Barbara. It's where rich people, it's beautiful there. Are there really street people? Yes, there's street people everywhere. Why street medicine? Because it's extremely dangerous to be an unsheltered homeless person. There's a very high mortality rate. I don't have a lot of time to go over the data, but I'm going to show you some data very quickly. But this picture speaks so many words to me. This is little Rick. He was one of our first patients of Doctors Without Walls. He had been sober for a week, and his dream was to get shelter, but he couldn't get shelter until he was sober. So he got sober, got into shelter. Look at his face, the dignity, and then he went back to drinking. So when you see the people's faces, you see in their faces the dignity that they gain when they're able to achieve housing and sobriety. It's so powerful. And little Rick died several weeks after this picture was taken on the sidewalk and froze to death in Santa Barbara. And we wept. This is a shame. Shame on us. Shame on us for having a man die on our sidewalk in Santa Barbara. So this is the thing that, this gives us passion for the work. And, no talk about street medicine would be complete without speaking about Jim O'Connell and the brilliant work being done at Boston Healthcare for the Homeless Program, which is one of the premier programs in the world for work looking at homelessness. And I'm just going to go through these slides very quickly, but just so you know this data, and I want to read you this quote from Pat Perry, who is actually at the Street Medicine Symposium now. Based on the data, chronic street homelessness has a 5-year mortality of 30%. When chronic street homelessness is framed as a medical problem, there is no other reasonably common disease affecting people in their 40s with a 5-year mortality that high. Hence the observation from our contacts at the CDC that this is the highest adult mortality rate in any subpopulation in the US, and were a more prevalent disease, the CDC would brand it an epidemic public health crisis, okay? Mortality incredibly high, and people die young. So this is data from Boston Health from the Homeless, from a study in Annals of Internal Medicine, looking at a cohort of 17,000 people, and median age of death 47, okay? People die young on the street. This is a high-risk cohort that they've been following at Healthcare for the Homeless, Boston, 119 chronically homeless people, following them over 5 years with certain risk factors that were pulled out of the data, looking at what are the risk factors that make people more likely to die. After 5 years, 32% of this cohort were dead. Okay, so people die young and they die frequently from unsheltered homelessness. And this data, I mean, frequent flyers, street homeless, look at this data. Whoops, I want to go back to this. This group, 119 people between 1999 and 2003, look at the number of emergency room visits they had, 18,000. Do you think they're getting primary care, this cohort? No. So that's the point. That's why we do it. That's why we do street medicine. It's to bring care to very, very vulnerable people who are at risk of dying. And there's a really important organization. If you haven't heard of Common Ground, the 100,000 Homes campaign, it's really a fabulous organization, volunteer-driven. And the idea is identify the people who are at the highest risk of dying and get them housing. How are we going to heal them if they do not have housing? That's the whole idea behind Common Ground, and it's a fantastic organization. This woman, Becky Canis, has been really the charismatic leader. So, this is a picture of Father John, one of our founding members of Doctors Without Walls. He went to Katrina. He's sitting here with the chief of police in Katrina, who's now homeless. So we know the connection between disasters and homelessness. I mean, if a disaster strikes, we could all become homeless. So by learning how to take care of people living in the chronic disaster of homelessness, we learn how to take care of all of us if there were to be an earthquake or a hurricane. If any of you haven't seen this movie, I highly recommend it. Beasts of the Southern Wild is a fantastic movie, one of the best I've ever seen about homelessness, and it's out right now, so I just wanted to say, great movie about Katrina and homelessness that you should all see. So how do we provide medical care to people living in disaster? We learn at home, we start at home, train in your backyard, and then we can talk about going overseas. So this principle of thinking globally and acting locally is very, very important, and it's true. You know, we learn at home. So when you look at a disaster like Haiti and what happened after the earthquake, one of the things I see here, amidst all the suffering, is that it's a logistics collapse. And anytime we take care of people in disaster who have extreme need, logistics is going to be 80% of it. Logistics, logistics, logistics. So always you have to think about logistics. So when you're looking at, the super utilizers and how are you going to take care of these folks? Or what are you going to do? There's so many logistical issues that come into that. And that's why we need our multidisciplinary teams. There's also desperate, incredible need. And when people are living in disaster, the need is overwhelming. And this is where we learn to be better. We learn to be better doctors when we address people who are in crisis and in terrible need, because it elevates our practice. So this is a quote that I think about it a lot. Whoever destroys a soul, it is considered as if he destroyed an entire world. And whoever saves a life, it is considered as if he saved an entire world. So we can't save everybody. But if we save one person, one life, then we've saved a world. So we can remember this when we're faced with suffering. So I'm leaving tomorrow for Haiti. And this is with a great program called Project MediShare that is based at a hospital called Bernard Meves. And it's the only critical care hospital in Haiti. And we go with family doctors. It's a volunteer program. It's a week at a time. And I always go with family doctors. And this, on the left, is my dear friend Neil Jayasekara from Contra Costa. He's a family doctor who's an ER doctor. The woman he's hugging is a Haitian doctor. Here are the paramedics that work in the hospital. And it's so important to have family doctors in these environments because, for example, this is a young woman who came in. She was preeclamptic. She got an emergency C-section. She had a baby. She was afraid to breastfeed the baby because she couldn't get food. She didn't think she would have the nutrition. So we worked with her, with our Haitian partners in the hospital, convinced her to breastfeed. And I'm so excited because I'm going back and I'm going to see little baby Matthew this week, who's been thriving because, his mama was able to give him the nutrition from her own body, which we could help her to believe that she had that strength because we're family doctors. That's what we do. One of the things about Bernard Meves is that it's so dangerous, we're not allowed to leave the hospital. So unless you give blood. And for any of you that are interested in global health work, blood banking is a really big issue. But I love this poster in the blood bank. So we went and gave blood. It says, if someone falls down, you can go and help them or you can give blood. So we went and gave blood, and because of that, we were able to get out and see Haiti. Otherwise, we would have been locked in the hospital the whole time. And last year, the cathedral was still collapsed. There were people living there, enormous slums. And this is street medicine. These guys are selling pills. So I'll see what I'm going to see when I go back. But we talked about starting street medicine in Port-au-Prince, but it's much too dangerous at this point. There's too many violent crimes. So we do what we do. We can save a life. Okay, how much time do I have left, Larry? 5 minutes? Okay, I'm okay. I just didn't want to leave anything out. I want to talk about Africa. So, global health. This is an incredibly important time to be a family doctor, because with PEPFAR 1, which was the President's Emergency Plan for AIDS Relief, which was established in 2003 by President Bush, the focus was on vertical silos of care. And those silos were HIV, malaria, tuberculosis. So the way that this $15 billion was deployed from the federal government to Africa was in these vertical silos of care. So you can imagine the physicians and the clinicians who were responsible. A lot of infectious disease clinicians, like wonderful Paul Farmer, who's one of the great leaders of our time, emergency physicians and so on. With PEPFAR 2, there's been a shift. And the shift is to horizontal platforms of care. So with this shift, what's going to happen is that family medicine as a specialty is going to be introduced to countries in Africa. For example, Ethiopia. I'm going to talk about Ethiopia because I had the great privilege of going, which is a country that has no family doctors. They don't know what family medicine is. So this is a very important time to be a family doctor to help teach the world about what family medicine is and what family medicine can do. Because we know that if we have vertical silos of care, how is that going to really work long term? We need the horizontal platform. We need primary care. So this is just something about PEPFAR 2 that we're building on the vertical silos of care created by PEPFAR 1. Hillary Clinton, State Department, she's responsible for pushing this out. So I had the opportunity to go to Ethiopia in March with a nonprofit called Ethiopia Health Aid. And the focus of Ethiopia Health Aid is bringing primary care and health care to rural Ethiopia. And it's led by an Ethiopian surgeon at California Hospital in Los Angeles named Dr. Gudata Hineka. Any good program needs to have local roots. This is just a map of where we were. Here's Addis Ababa, here's Adama, and we go out to Arsi Negele and Gode, which are rural areas where there's no hospitals. This is the hospital where we worked, and this man, Mr. Kabir, is a very wealthy Ethiopian businessman who built this hospital because of his love for the Ethiopian people. But he built this beautiful hospital, but now he needs help with teaching the Ethiopian doctors about primary care, so that's where we came in. So this was a medical surgical team, and I just want to mention a couple points about why it's so important for family doctors to be present in global health. Here we have a radiologist from our team from the United States, an Ethiopian radiologist, and we're looking at a tumor on a baby. And then, of course, you need the family doctor to keep the baby happy and to do the pediatrics. But also, here was a woman who came in, she had multi-infarct dementia. In Ethiopia, there's not an understanding of how do we take care of elderly people with dementia. And her family had no idea that she wasn't going to get better. And so I was working with my translator, who's actually a nurse in Michigan, and she's Mr. Kabir's daughter, to talk to them about, she's not going to get better, and what are you going to do to help your mom, to get through the next years of her life with dementia? It was something that they just didn't know about. Another case that came in was a man who was dying, and there was no understanding about palliative care. So we were able to, during our time there, to teach them, our colleagues, about palliative care and how to help someone who's suffering at the end of life to die. And this was his wife, who I was able to just, comfort her as he was dying. So teaching, learning, healing, this is always what global health is about. Beautiful people of Ethiopia. This is an important picture to me because this man, Dr. Muhammad, is one of the most famous surgeons in Ethiopia. And here we are, a surgeon and a family doctor, a Muslim and a Jew, an African and someone from the United States, and there's no space in between us because we've been working together, teaching, learning, healing, and it just uplifts everybody, ourselves, and it was just a beautiful experience. If you love Ethiopia, this is a great book. Abraham Verghese. Okay, so I'm going to bring it home talking about VIPs. I know I've probably got 5 minutes left. The thing that is very surprising that I discovered when I started taking care of celebrities, none of the pictures are of the people I take care of, obviously, is that there's so much similarity between the unsheltered homeless people that I take care of and the most extremely famous rich people because of the barriers to care. So as family doctors, if we can, and there's no family medicine either, because there's all these specialty cares. You know, people go to often just to this specialist or that specialist, this guru. If we can bring family medicine to all people, we're gonna take care of everybody better. So I just want to make some parallels for you here. The dehumanization. Do you see a person or do you see an icon? This is Wizard from Isla Vista. He's a chronically unsheltered person, and then Marilyn Monroe, of course. But when we don't see a person as a person, we see them as an icon, we can't take good care of them. Also, disrespect. You know, I'm sure you can think of many examples of unsheltered homeless people who've set on fire, kicked, spit on, called horrible names. But then we see images like this of Lady Diana, who was hounded by the paparazzi, and Britney Spears as well. How can a human trust a doctor to take care of them when they can't even trust the people that are all about them on the street? The other issue about lack of trust is it's very hard, and I found this striking image when I was in Hawaii on a vacation, and we went on a drive looking for dolphins to go diving, and I discovered on Oahu this 13-mile stretch of beach where there's one homeless encampment after another that nobody seems to talk about. There are all these unsheltered homeless, or they're sheltered but intense on the beach. And as I took pictures, I found this one picture, and it was a really striking contradiction here, but this is Heath Ledger. It's a very shocking picture, and in his home, and I don't know if you can see what it says down here in this sign, but there's this incredible barrier. You know, go away, leave me alone, don't take care of me, get away from me. How do we get through that as doctors? How do we reach through that to take care of someone, to try and heal them? Other thing is fragmentation of care. It's a very big challenge with populations that are in extremes of wealth. A perfect example of that is Howard Hughes, you know, with the stories about what happened to him at the end of his life. And then, you know, when you try and take care of unsheltered homeless people, there's just not the continuity present. So what comes down to me ultimately is Maslow's triangles of need. So if you look at the bottom of this triangle, where people are when they have no feeling of safety, they feel that they're being, you know, that they can't trust anybody around them. And perhaps they don't even have their basic physiological needs taken care of because there's a lack of trust. That's where we can really help people as family doctors. We focus on the bottom of that triangle of need, at making people feel safe, addressing their fundamental issues of housing, you know, and access to care. That's when we can make ourselves better and make them better, and then we can actually lift people up. So this is a picture of Jim Withers that he shows a lot, where he is. I know I'm not supposed to be standing over there, sorry. He shows us a lot. This is the transfer of trust. This is how it happens. When we have people that are alienated and the care is fragmented, they're not getting coordination, the transfer of trust happens person to person. This is Jim, and he's introducing this chronically unsheltered schizophrenic man to a psychiatrist, and he's transferring the trust like this. This is how it has to happen. That's why we need multidisciplinary teams. That's why we need to meet people where they are. That's why we have to work together. It's all about that transfer of trust. So Paul Farmer says, for me, an area of moral clarity is you're in front of someone who's suffering and you have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. Another pearl of wisdom from Chris Farnatano, one of my teachers: make every interaction an opportunity to build the therapeutic relationship. I think about that a lot. This is a VIP. This man is named Delbert. He lives in Santa Barbara. He's a veteran, a combat veteran. He had full benefits from the Veterans Administration, but nobody in Santa Barbara could help him because he wouldn't let anyone close to him. He lived in this hut called Frankenstein that he made. And he had squamous cell carcinoma all over his head. It was burrowing, you could see the bone. And our team was able to make connections with him. This is our social worker, Jennifer Ferez, and we were able to get him surgery, and now he's housed. He's a VIP because once we get connections with Delbert, then we have the trust of the entire community. We have pathways into that trust. So when we think about who are the VIPs in our community, it might be the unsheltered homeless person that won't talk to anybody, or it might be the mayor, or it might be your boss's mother. It's whoever those people are in the community that we really need to reach out to lift ourselves up. And I just want to finish up with two quotes from Rich Roberts. As I said, I was at Global Health Conference recently, and he gave a tremendous talk, really, called Formula for a Better World, Primary Care is Global Health. Primary care is global health. And he said this in his talk: all family physicians serve the poor. If we also serve the well-off, society will be changed. And then he said, if you want your country to embrace primary care, you must be sure that everyone, from the president on down, has a primary care physician. This is true. So we just need to remember that when we do reach out to people, whether they're unsheltered or whether of great wealth, there can be barriers to care. And by working together and with interdisciplinary teams, being patient, remembering that that 20% is there to make us better, I think we can do it. So témoignage, I just want to mention this term used by Doctors Without Borders, is to witness. Just being there, just witnessing and being with someone during their time of suffering is an important act. And I'll end with Dr. Martin Luther King. We are prone to judge success by the index of our salaries or the size of our automobiles, rather than by the quality of our service relationship to humanity. Thank you. That's it. Thank you.